Okay, welcome back. Chapter 11, we're moving into part 5, dysfunctions of the nervous system. So with these dysfunctions, there can be alterations. They have a list of things, but remember, motor function, cognition in general. We can also have decreased reflexes, incontinence, loss of bowel and bladder. Anything that you could think that we've studied thus far can be damaged. We're going to go through most of these disorders. There are several slides for each. I'm not trying to give you a ton of things to remember. I'm trying to make sure I'm clarifying everything so it's as clear as possible. And here we have even more. Okay, we'll go through these one by one. So hydrocephalus is a common condition of excess cerebral spinal fluid which can accumulate within the skull, or cerebral spinal fluid can't get out through the jugulars. Could be one or the other. The ventricles can dilate, which would push up on the brain and blood vessels, compressing them. It could also push down on the brainstem, pushing that brainstem down into the foramen magnum. If it continues, it can be fatal if left untreated, especially in adults, because adults, the brain can expand. The skull and the dura mater can't expand. In children, if they have an open fontanelle, it can actually push up through that fontanelle in hydrocephalus, and it would actually prevent damage to the brain itself. Treatment would be surgical repair of the blockage or shunt placement. So here is a picture of, you can see the ventricles in the center. If they dilate, they'll push up on that brain. They can also push the brainstem down. So hydrocephalus manifestations will be different in infants than adults and older children. After a year, that fontanelle closes in the front, that anterior fontanelle, which we spoke about previously. In children, it'll push up through that fontanelle, which would actually push the head. It could push some of the bones of the skull apart as well. But that spreading of the bones would prevent brain damage, although it would cause the bones to spread apart. But in older children and adults, the skull is solid. It's fused together, so it would push down into the brain, and it could cause any neurological symptom you could think of. Double vision, blurred vision, nausea, vomiting, dizziness, extreme headache, beyond your typical headache, like a searing headache, photophobia, anything you could think of. Okay, so moving on to spina bifida. So this is a neural tube defect. As a child develops, basically what happens with the vertebra is they come back and they form a tube. So if I were to take one of my vertebrae out of my spine, and that's the vertebral body, and we're looking down on it, the way that they're structured, not bad. Okay, so this would be the front or the anterior. You're looking down in on the vertebra. Here's the vertebral body on which the discs would sit. These are the spinous process back here that you would feel as bumps on your spine. And your spinal cord sits in this nice bony ring that your vertebra forms. With spina bifida, what happens is, seeing if I can make a different color here. I can. Is this back part doesn't fuse together, and it actually will stay open. And if it's just a small opening, it's fine. But the opening as the disease progresses, and what I mean by that is not a person who has the mild form, it will progress the more advanced form. I mean, as a patient gets a worse form of spina bifida, because there's varying degrees of it from very mild to very debilitating. So in the progressed form, that opening is wider, and you can get the meninges coming out the back. And if it progresses to the next form, the meninges and the spinal cord come out. Okay, and we're going to go through each step, but I just wanted to give you a visual. So in normal patients that vertebra would fuse back together, and people with spina bifida, it stays open. So this is most common in the lumbar site. You can get openings along the spine all the way up to the skull, where the skull is not closed and the brain actually comes out. So spina bifida occulta is that mild form. There's just a small gap in the back. Usually there's no issue. They don't even need surgery. The spinal nerves and meninges are still in that vertebra. The only way that this is often found is on x-ray. They'll see that there's a non-union in the back of that vertebra on x-ray, but these patients also have quite often a dimple, a birthmark, or a tuft of hair over the area that it's not fused in the back of that vertebra. So this form is called spina bifida occulta, and I always remembered it as being a mild form because it's like a cult who stays hidden. Now, these next two forms, meningocele and myelomeningocele, are rarer forms. I believe they used to be called spina bifida vera. Okay, but they've broken them down into more specific forms. So, meningocele is when there's non-union of that vertebra in the back, and the meninges and cerebral spinal fluid form a sac on the surface of the back. So, the spinal cord stays in the vertebra, as I showed you. So this will be a bulging of the meninges and the cerebral spinal fluid. Okay. This is why I think it's important to get checked as the baby's developing, because if they have this form or the next form, they're going to have surgery. So the next form is myelomeningocele. Oh, here's the next. Sorry, I thought they were moving on to myelo. So membranes can be removed by surgery with little or no damage. Infection or rupture of the sac can lead to neurological impairment because you would get that infection into the spinal cord. Okay, myelomeningocele or open spina bifida is the most severe form. This is when the meninges, spinal cord, spinal nerve, cerebral spinal fluid are open. Skin may cover the sac in some cases. It still needs to be corrected surgically because the spinal cord is out and can be hit or damaged. So tissue and nerves are most often exposed though. So this would obviously lead to neurological impairment, bowel and bladder problems, seizures, other medical complications. This would have to be surgically repaired. So cerebral palsy is going to be a permanent motor damage to the muscles of coordination and voluntary muscle movement. There may be other cerebral dysfunctions such as cognition and communication. This is usually damage we see during childbirth if the child is forced out. Can occur anytime during the first 3 years of life though if they have some sort of trauma. Can also be caused by brain abnormalities or congenital malformations. So, may or may not be evident at birth. It may present in multiple ways. So the persistence of early reflexes, such as a positive Babinski sign, I didn't go over that, but that is when the foot dorsiflexes or comes up and back. You'll learn about that in orthoneuro. There's superficial reflexes that should not be present, and if they are present, it's a sign of central nervous system damage in the brain or the spinal cord. So you'll go through those upper motor neuron reflexes in the future. Anyway, there could be developmental delays. There can be something called ataxia. Ataxia is a broad-based gait where they step really wide. There could be spasticity in their muscles where their muscles start to bunch up, like they're moving towards that fetal position, where their arms come up or the knees can come up. They might have hyperreflexia, whereas if you test their patellar reflex, they would have an over response. They might have an abnormal asymmetrical gait. They might drag a foot when walking, probably be in a wheelchair. Unusual positioning of limbs when resting or held up, once again moving into that spastic fetal position. They could have drooling, difficulty swallowing, impaired suckling, depending on where that trauma is. If it's up at the brainstem, once again, they won't have good motor control because some cranial nerves can be damaged. Difficulty talking, difficulty with facial movements, tremors, and difficulty with precise motions. Quite often this will happen at the brainstem, so it could affect those cranial nerves. There could be damage in the brain itself too, which would inhibit the coordination of movements. And that can happen at the basal ganglia or the cerebellum. So complicated. There's so much to know. All right, so let's practice a few of these. And once again, guys, I'm not going to ask you super specific things with all these diseases. I want you to have a general working knowledge of each one. All right, so out of the diseases that we just studied, what might you think this would be? The circle is obviously around it. We're going to be looking at the lumbosacral spine on X-ray, very bottom of the lumbar spine, upper sacral. Does it look like that is fused together in the back? It's a little hard to see. I can tell you this is normal. This is normal. Oh, I'm liking the blue. This is non-union in the posterior vertebra. I think this actually might be top of the sacrum, but you get the idea. So this would be spina bifida occulta. This probably is somebody that had back pain, never knew that they had spina bifida unless they have those surface attributes. And when they took the x-ray, you could see there's non-union of that vertebra showing spina bifida. What do you think this might be? Thinking about what we have talked about. Big hint, you got an arrow pointing right at it. What ventricle is this? What's happened to it? What would happen to the brain tissue above it and below it? This would be hydrocephalus. And it's pushing up on that brain tissue and down on the brain stem. It'll also thin the brain matter, as a side note. I like these pictures. Yeah, this is going to be myelomeningocele, where that comes out, all right, and that would have to be surgically repaired. All right, let's practice. So there's multiple ones on here. Okay, this first one here, I'm going to click on. This is going to be which form of spina bifida? Spina bifida vera. Good. This will be which form? Meningocele. Those will just be the meninges and cerebrospinal fluid. This last one would be myelomeningocele. So there's those three forms, and I thought those were great pictures of how they progress as well. What do you think this might be? Oh, the answer's at the top. Cerebral palsy. Okay, so I also liked this picture. I thought I had them all covered because it shows you different types. Now, there's partial involvement, total body involvement, and this is actually a gait involvement. It shows you a picture at the cerebellum. This actually shows damage in the basal ganglia. I know you don't know that, but I'm just letting you know. This shows motor area involvement in the frontal lobe. And the reason I'm showing that to you is because this motor involvement will actually present with people with cerebral palsy as stiff muscles. They could have hemiplegia, which is half the body, diplegia, which would only be two extremities, most likely the lower extremities, maybe part of the upper extremities, and quad meaning four would mean all four extremities would be involved. Okay, so with cerebral palsy, you could get spasticity in these muscles. You could also get uncontrolled movement, more like a writhing, continuously abnormal, uncontrolled movement, which is called dyskinetic. And once again, I'll test you from the notes, but I just thought this was an interesting addendum to the cerebral palsy. The other thing that you do need to know is ataxia. Ataxia will come from the cerebellum. Ataxia is a broad-based gait. Always remember ataxia because if you drink, it affects the cerebellum and you have that ataxic broad-based gait, trying to realize where you are in space. All right. So meningitis is going to be an inflammation or infection in the meninges. Okay. This could be something other than an infection. Quite often it's from the infection. This can get into the cerebral spinal fluid as well. If it gets into the cerebral spinal fluid, it'll probably go to the brain and cause encephalitis, which is on the next slide. Meningitis is mostly likely bacterial viral. It could be fungal as well. Because there's an infection in the cerebral spinal fluid, usually with an infection, we'll draw inflammatory processes to it that'll push out on the ventricles, increasing the internal cerebral pressure or internal cranial pressure. Can be self-limiting, which is viral, or life-threatening, which is acute bacterial. Typical signs of this that you should know are a stiff neck, and not just like, oh, I pulled my neck. Like, you can just tell with these people. They have a very stiff neck that if they drop their head forward at all, it causes pain, which goes down the spinal cord. Because you have inflammation around those meninges, you're going to have a lot more pressure on the spinal cord, and nerves do not like pressure. So if they drop their head forward even a tiny bit, it'll traction the spinal cord, and it'll cause pain, which will go right up into the head and down the spinal cord, because once again, nerves don't like pressure. They have a severe headache, and this is not like I need to lay down for an hour headache. It's like I can't lift my head up. And they have photophobia, where they can barely open their eyes. So that triad of signs and symptoms are pretty like, this is meningitis, and they need to be tested. Okay, if the inflammation spreads to the brain, it leads to encephalitis. This can also be viral or bacterial. This inflammation can be a continuation of meningitis. It causes cerebral edema, which would cause pressure. You can have hemorrhaging and brain damage. So similar manifestations to meningitis, but with a more gradual onset. So traumatic brain injury, or TBI, this could be some sort of accident that would happen, or a violent blow or a jolt or penetrating head wound. Quite often where we see TBIs is going to be car accidents, where people's heads get flung forward and backwards. This can lead to concussions, which is, the swelling of the brain, or contusion, which is a bruise of the brain where some of the blood vessels open up. So you can damage nerves, you can cause bleeding, multitude of causes. So not being able to recall event details, indications of concussion, changes or unequal pupil size, seizures, asymmetrical features, facial features. I think those are all pretty self-explanatory, and I think that's kind of bread and butter stuff. So I'm going to move on with that. I like this picture because it shows you how the head could be flung forward and backwards, okay? And it can cause damage to the brain. But the other reason I like it is, remember, if you fling the head forward and hit something, quite often there'll be a rebound effect. And the brain is just sitting a little bit of cerebral spinal fluid. So even though you may not hit the backside of the head, the brain will fling back as the head flings back and hit the skull. Okay, so they show you all these different directions, and they, I think, label them in your book. I think if you just have the general working knowledge of the head being flung back and forth, you realize that not only might the brain hit forward, if you hit something forward, as the head rebounds backwards, the brain can actually hit into the skull, damaging the brain even further. So increased intracranial pressure is just simply going to be an increase in volume in the cranial cavity. Multiple things can cause this: hydrocephalus, tumors, edema, hemorrhage, TBI that we just spoke about. And one of the things that they mention in your book is the Monro-Kelly hypothesis. And it's really simple. It's just that an increase in volume of one component has to be compensated by the loss or a decrease in volume of another. Okay, so this will either decrease the amount of cerebral spinal fluid or blood volume that is in the cranium. So don't make this a big thing. I could just see this as I always wonder what they're going to put on your boards. I could see this being a board question. And I looked for pictures that might help you with this. And this was, I know, hand sketched and so simple, but I think it really helps to get the concept across. So if we look at this side, this is normal. And in a normal brain, we'll have this amount of brain tissue, about, half the cranium, about a fourth will be blood and about a fourth cerebral spinal fluid. If you have a tumor, you can't really get rid of brain tissue, can you? So that tumor will take up some space, and it will allot for a smaller amount of cerebral spinal fluid and a smaller amount of blood, which decreases the amount that the brain can function. It'll also put pressure on that brain tissue and probably start to damage or kill it. Necrose it. Herniation. I spoke about increased cranial pressure due to hydrocephalus, tumors, anything like that will push the brain down. The cerebral hemisphere is at the bottom, part of the diencephalon, the midbrain, the brainstem, the cerebellum, things called the uncus can go down in through that foramen magnum and get compressed into it. The problem with that is now we can't get the proper blood in. It could compress cerebral spinal fluid. It could press down on the reticular activation system, leading to coma. It could also decrease or impair respirations with herniation. There's a whole bunch of different types of herniations. I just want you to know about it in general. And I thought this was a really great picture. So they have an example of some sort of injury causing a blood clot. That blood clot is pushing down on the brain tissue. Here is the base of the skull. So this is the foramen magnum. And what happens is we start to push, in this picture, the cerebellum down through that foramen magnum, but we're also pushing brain tissue into the brainstem. And once again, nerves don't like pressure. When we put pressure on nerves, they will start to dysfunction and not work appropriately. Think about the sciatic nerve. So many people have pressure on their sciatic nerve, either from tight muscles or a herniated disc. How do people feel when they have pressure on their sciatic nerve? Constantly irritated. That's what happens to any of the nerves in the body if we have abnormal pressure on them. And this herniation is a problem because the brain stem is where all those vital functions are, and we start to put pressure on it, which not only puts pressure on the nerves, it'll decrease the amount of blood flow to that tissue. Then it has double whammy of its ability to function. Here we are at another question time. Brain herniations could affect A, balance and coordination, B, consciousness, C, respiratory rate, D, all the above. Go ahead and answer that. We're going to go through a few more slides. Okay, so manifestations of increased intracranial pressure. You name it, it happens, especially if it affects brainstem functions or cranial nerve functions. Okay. In infants, you could have the sutures separate and have a bulging fontanelle and an increase in head size. In older children and adults, the head won't enlarge because the skull is fused, but you could get all of those neurological deficits that we spoke about earlier. Now, there's a Glasgow scale, and I'm sure this sounds familiar. This is the coma scale. This is the one in your book, and it has numbers according to their responses to cognizant, see how cognizant they are. And so here's a list. You can go through that on your own. I'm sure it looks familiar, but I put another list in for you. And the reason I did is at the bottom, it gives you what's an appropriate response to comatose to totally unresponsive. So just as a sidebar, I put that down below, but they're pretty similar, both of those scales. So vital size changes with that increased intracranial pressure. You have a decrease in pulse, a decrease in respiration, and you'll have an increase in that pulse pressure. Well, you'll have an increased difference between systolic and diastolic numbers. Hematoma is a nice segue because increased intracranial pressure could come from this. And this would be a collection of blood that'll collect from ruptured blood vessels. So this could be after a traumatic brain injury or surgery. They can form in different layers. We spoke about dura, arachnoid, and pia. So epidural will be on top of the dura. So this will be between the dura and the skull. This is usually an arterial tear. This can manifest as neurological dysfunctions because it can push on the brain. All right? So they may have a brief loss of consciousness, a short period of alertness, and then another loss of consciousness again. Subdural will be beneath the dura, but above the arachnoid, and it usually is a small venous tear. Excuse me. This is going to be slower. It may manifest within 24 hours after an injury. It says it can progress rapidly. I don't think this is going to be nearly as bad as a subarachnoid. If it progresses, though, and it isn't stopped, you could have death because of pressure on it, and it pushes down on the brain and the brainstem. Okay, subarachnoid, let's continue with that. It's going to be underneath the arachnoid and the pia. You will present with bleeding because we have blood vessels in there, but they also could have a severe headache because of the pressure on the brain itself and also the infection that's getting into the cerebral spinal fluid. Now, intracranial hematomas would be bleeding in the brain tissue itself. There's a ton of blood vessels that go into the brain tissue to keep that blood nourished with glucose and oxygen. So this could be a real problem if you get a hematoma into the brain matter itself. Whatever brain matter is not getting blood could actually die and necrose. This could be a contusion, shearing injury. This could be hypertension and a blood vessel that's open. It could be a stroke, causing either a blood clot or an opening, an aneurysm in the blood vessels, or you could get vascular abnormalities that people are born with. Excuse me. The manifestations of this would be according to where it's located in that patient's brain. All right, let's practice. So these are different hematomas. I want you to look at them for a minute and tell me which ones you think they are. So in order to tell, and not all of them are on here, just a few. So in order to tell and give you a little reference, this, guys, is the dura mater. Okay, so if you need to pause the tape, go ahead and do so. Otherwise, we're going to take a look at this one in the upper right-hand corner. So this would be an epidural. It's on top of the dura. It's between the skull and the dura. It still will put pressure on the brain. Moving down, this one would be intracerebral hematoma. This is in the brain tissue itself. Last but not least, this one, that's going to be subdural hematoma. So that'll be underneath the dura. It'll be above the arachnoid, and that can also cause pressure and damage into the brain itself. All right, at this point, I'm going to take a little break, and I will see you as we move into spinal cord injuries. If you have any questions, let me know. Thank you so much. See you in the next video.